Good morning, everybody. Hope you found a seat. It's really great to see everybody this morning. I've just got a few opening remarks to make. I'm Thea, I'm Chief Exec of the Nuffield Trust. You're very welcome here today to this event. We're really pleased to be having this event, digging into three of the strands around the more I think about it, really oddly named shift, hospital to home. And maybe we can reflect a bit more on why I think this is such an oddly named shift as we go through the morning. And we'll be talking about services that rely less on hospitals, that really understand what community is. We're going to be talking about primary care, we're going to be talking about social care. So probably the three parts of the stool that really are significant in the community, as well obviously as the VCSE sector. Some of the very practical things I need to say is this event wouldn't have been possible without the support of the Nuffield Foundation, who helped us with the work that we did coming up to the election, and also to Optum, who unfortunately aren't here today but have helped sponsor it. We're live streaming this event. We have a photographer. If you don't want your photograph taken, then please make sure that that individual knows. If you want to get involved in the conversation on social media, whether that's X or Blue Sky, use the hashtag hospital to home, please. For Wi-Fi, you can go to 1 Great George Street. There's no code, you just get straight onto it. And please put your phones to silent if you possibly could. It's a very packed morning, so we are going to be relying on Isabel, our very wonderful chair for the morning, to make sure that people move through this. We've got a lot of information to get through, but we hope that we'll carry on the conversation in the coffee breaks, in other places, and I'm sure for many months to come going forward. We'll finish at 12:25, and we have lunch until 1 o'clock. Anyway, so without further ado, I'm going to hand over to Isabel.
Oh, well, Thea, thank you so much for having me. Delighted to be here with so many people who I know so well, who've helped me understand the NHS a little bit better. I'm Isabel Hardman. I'm assistant editor at The Spectator, also author of Fighting for Life, a biography of the NHS, which you can find in all good bookshops. And I'm delighted to have our first panel on international lessons for hospital to home. We're going to start with a presentation and then move to a panel discussion. And we really do have a wonderful panel here this morning. So we have Nigel Edwards, advisor of the World Health Organization, Sally Gainsbury, senior policy analyst at the Nuffield Trust, Helen Morgan, MP for North Shropshire and Liberal Democrat spokesman for Health and Social Care, and Sarah Reed, who is senior fellow at the Nuffield Trust. And Sarah is going to start with a presentation on international models and how they can be applied to England, which I think is going to be really interesting, particularly given the sort of exceptionalism that we suffer from in Britain in thinking that our health service is the envy of the world, and how could we possibly learn from any other model? Or certainly that's the political discourse that we still often have. So I'm looking forward to Sarah opening up the discussion to a more international perspective. Thanks, you, Sarah.
Isabel. Yeah, so I'm going to start us off this morning really talking through, as Isabel said, when we looked internationally to try to understand what other countries who seem to be really good at this, making this shift happen, what kind of sets them apart, where we might be able to learn lessons in the UK. So before I get into what those lessons are, I did just want to take a moment to say a bit more about how we're approaching this work and which countries we focused on and why. Sorry, that's so small. But yeah, when we started asking this question, we started by looking at what other health systems out there, like the UK, seem to have low numbers of acute hospital beds relative to other high-income countries, and therefore might have kind of similar constraints and pressures as we do in the NHS to move patients out into the community and free up that limited capacity for patients who need it most. And when we looked at how this cohort of countries perform on things like length of stay in hospital, we really focused there because, of course, length of stay in hospital can reflect many things, but it can reflect a lack of care coordination, and it can indeed mean that there's insufficient community supports to make this shift happen in the first place. And you'll see from this chart here that compared to some of our peer group of countries, which include kind of the Scandinavian countries, the Netherlands, Ireland's in there, when we look at how we perform relative to these countries, our lengths of stay in hospital are a bit longer than you'd expect them to be. So a British patient stays in hospital roughly 2 to 3 days on average than, say, a Danish or Dutch patient. And that's, of course, just an average. When we look at different disease areas, we see much starker differences. So we know, for example, patients in England who've had a hip replacement stay in hospital a lot longer than some of the health systems described here. And of course, this is not causation, this is a correlation. There's lots of other things that could be at play here that have nothing to do with community capacity that explain this pattern. But we thought this is a helpful cohort of countries to start looking at, try to understand what they're doing potentially differently, where there might be lessons. So when I speak to what we've learned, those are the cohort of countries that we're talking about. So what are those lessons? And because of time, I'm just going to focus on sort of the three biggest things that have stood out to us in doing this work, and I'm sure we can get into a lot more in the discussion. But the first lesson, and we do say this a lot about a lot of things, but we say it because it is true, is that if we want this shift to happen, we need to put our money where our mouth is. In these other countries, you'll see here from this chart, they have tended over time to allocate more of their healthcare resources towards these non-acute services. So they've invested more historically in things like primary care, long-term care, rehabilitation services. And as the Darzi review made really clear, this has translated into things like these health systems having more beds, more staff working in these community settings to be able to make this shift happen. And I know this chart might not look that dramatic in terms of the percentages on the screen, but also remember that these health systems that I'm describing here, particularly Sweden, Norway, the Netherlands, Denmark, they spend a lot more on health in general. So this is a bigger percentage of a bigger pie, which actually translates into quite differences in the material resources going into these sectors. And in England, we've had a similar desire to kind of redirect our resources in this way. And my colleague Sally has looked at this much more closely in our experience over time. So we'll get into that in the discussion, but just to say kind of the opposite of what we've intended to happen is what's played out in the UK, with growth in hospital and acute services growing at a much faster pace than anything we've seen in the community. This gets me to the next, but very much interrelated lesson, that of course, long-term plans are just the start, and they won't make a difference if they're not meaningfully backed with a long-term commitment, both financial and otherwise, and that aligned policy thinking. And I'll use the Danish experience here as an example. So there really has been a consistent thread in the Danish policy making about making this shift happen and kind of moving more care out of hospitals incrementally over time. But in that long journey, they've done some pretty major things. In 2007, for example, the government wanted to do two things. They wanted to really modernize their hospital sector, so make sure that their hospitals were working as efficiently and productively as possible, turn them into state-of-the-art facilities, and at the same time, to be able to make that happen, really expand community capacity to really take more pressure off of hospitals to be able to do this well. And to do that, the Danish government they roughly cut the number of hospitals they have in the country by half, and they took what remaining hospital stock they had and they turned them into these large, specialized, regionalized centers of care with state-of-the-art architecture and technology. And crucially, they took those, rather than just take something away from communities, they took those small and mid-sized hospitals and they turned them into more community capacity. So they put into local places things like rehabilitation centers, social care centers, what they call local specialized outpatient facilities where you could get an x-ray or a diagnostic test done closer to your home. A lot of the types of things our government is talking about now. And they also changed the financial incentives in the system. So there where local authorities are what oversee community services and the regions which oversee hospitals and other acute services, they had these groups come together to actually co-fund hospital admissions and at the same time introduce things like penalties so that if a patient's ever in hospital for too long because of a lack of community capacity, the councils actually pay a penalty for that to the regions. So there's some really baked in hard financial incentives alongside these reforms to make some of this happen. And two things kind of stand out to me in the Danish experience. One, it took a long time to see the benefits of these efforts. So 10 years down the road, that's where the government could say, we've reduced our inpatient spend by about 15%. We're seeing more of our staff now working in these community settings. It took a long concerted effort. These changes did not happen quickly. They've seen their hospital productivity start to go up 2% year on year. And this is similar to what we've seen in some of the other countries I've said. Ireland has been on a similar journey to try to move more of their care out of hospital, they're about year 8 or 9 into their 10-year journey. And when I speak to Irish experts, the thing I hear is that it's now that we're starting to see the positive changes of this effect. And I know in the UK political system, this is really hard. There's very few incentives. We can write long-term plans, but there's very few incentives there to really commit to projects and plans that take a decade to see the benefit. So that is something that's difficult in our own context, but is definitely true in the countries I see. And the other thing is that this all took upfront investment. I know the government says that we really need reform, not investment, to be doing the heavy lifting of making the shift happen, but it's really hard to see how the Danish experience, or indeed some of the Irish experience or other countries we've talked about, how that could have happened without big upfront investments in things like improving their infrastructure in their community centers and hospitals, and things like getting the data right and upskilling staff in the right way. All of that took a lot of resources and a willingness to see this through over the long term. That will bring me to my next lesson, and we have a whole session on social care, so I'm not going to get into a lot of detail here, but I think I'd be really remiss if I didn't at least point out that of the countries I've described here, Sweden, Norway, Denmark, the Netherlands, all of them have a functional social care system. And it's hard to talk about this shift happening without that in place in these different countries. So all those health systems I've just named, they provide social care that's based on need, not the ability to pay in each of these countries. And I know there's some real differences in some of these countries in terms of the welfare state and the different historical and political contexts they have that can make it really hard to transfer to the UK. But I think in these systems, there's been a real willingness to take on social care reform and think of it as being on equal footing, an essential part of this conversation, and not something to separate out and deal with separately through its own reform. So I think I wanted to make that point because it's just something that's really stark and clear when we look at the experiences of some of these countries. So that's just a taster. You'll notice that I didn't focus on interventions or models of care a lot. I talked about big contextual system factors, and that's because a lot of the specific models and the way they've changed service delivery looks a lot like the things that we're already doing here in the UK. It's these broader contextual things that are innate in their systems that have made those models work more effectively and better to make this shift happen that really stands out to me when doing this work. So I'll leave it there, Isabel, and carry on the chat.
Thank you so much, Sarah. That was absolutely fascinating. I don't think I've ever heard one of the phrases that you used, which was there is a willingness to take on social care reform. So that's a nice moment early on today. I was really struck by some of the points you made about penalties for local authorities. And I'd like the panel to reflect on this during our discussion. My sort of instinctive reaction to this is if we did this in this country, local government would just fall over. Because the penalties would be a sort of daily thing rather than a kind of one-off, oh gosh, we've had a few patients who've overstayed because we haven't found them a social care package. It would be too difficult to set that up given our wider context.
We have actually tried it.
We've tried it
as a model. It didn't. I think it's fair to say it didn't really work.
No.
It's an important lesson. I think Alan Milburn went on a health policy tourism expedition and brought back a number of ideas. And if you bring them back without the context, and of course the relationship with local authorities is very important on a number of other dimensions. So it doesn't really help if you're having an argument about finding them over here while trying to develop relationships over there.
In practice, they'd often be suspended because there was a realisation that fining the local authority would actually do exactly as you say, leadership falling over and wouldn't help.
Yeah, make it hard
and
to
I
find
think
that.
exactly that. Sally and I are completely right. We've tried that, it failed, but I think it's also because these countries have a relatively strong community sector where it's like, I think if you penalized local authorities here, like you said, they're starting from such a different place. So I think, some of those things we have to think about this broader context. They have a thriving social care system. These things aren't as extreme in those contexts, so they work differently. So if we don't fix some of those foundational issues, some of these specific levers just would be misapplied here, I think.
I feel like there's potential for us to all get very despondent very quickly about the position that we are in this country. Helen, perhaps you can cheer us up. Along with wetsuits, health and social care was a key focal point of your election campaign. And fortunately, the former has continued and there haven't been so many wetsuits since. So just give us a sense of where you as a party are going now on health and social care reform. You've obviously volunteered yourselves for the cross-party talks that are being set up, and that's something you've been calling for a long time. But how do you see your role and how do you see your policy developing with regard this huge shift in resources and how it can actually happen? Because I feel as though currently we have Wes Streeting pointing to where he wants the oil tanker to be, but not giving us any details on how he's going to turn it around and whether he knows where the levers are.
Yeah,
Do you know where they are? And can you tell us?
Well, I think that's an interesting question because obviously every problem that we have with every public service boils down to whether or not the Treasury considers that to be a worthwhile investment. And we have a difficult and economic outlook and a difficult economic inheritance for the new government as well. So I think that is the sort of the nub of the problem, and hopefully the lack of political consensus and the use of any kind of funding mechanism as a political football, we would hope that the cross-party talks will sort of get over. But I just wanted to reflect a little bit more on some of the things that you'd mentioned in your presentation, which was excellent. Thank you. The policies in our manifesto were really, really popular. When they were polled, they were some of the most popular policies of the whole general election. And that shouldn't come as a surprise to anybody because they were largely consistent with the recommendations of the Darzi review, and they reflected what people said to us on the doorstep every single day. I can't get a GP appointment. Where I live, ambulances are a real issue. There's a real ambulance handover problem in the hospital. The Acute Hospital Trust is a sucker-up of resources, and social care is absorbing a huge proportion of the council's budget. So all of those problems that everybody knows exists are sort of there in microcosm where I live and across the country. So the manifesto was designed to address some of those problems, and that's why it was popular. In terms of how you get to those big shifts, my background is in accounting, and it feels to me very much that we focus our efforts as a nation and in business on revenue spend versus capital spend. And revenue spend has to be balanced every year because the economy needs to know that you're not structurally spending more than you're raising in tax. And capital spend, obviously, people feel more relaxed about borrowing money for because you can see future benefits deriving from it. And that's a well-established principle. But what we're not doing is saying we need to switch the way we're spending revenue in order to drive savings in the future. So it is sort of capitally in nature, even though it comes under that revenue heading. So, for example, we know that it's much cheaper to care for somebody in a nursing home than in a hospital if they're at that stage of their rehabilitation. But what we've done is say to local authorities who might be responsible for paying for that, you have to set a balanced budget every single year, otherwise you're going to declare a Section 114 bankruptcy, effectively, and the NHS can run a deficit. Is broadly how it works. Our ICB is an enormous amount of in the red to an enormous extent. So the incentive locally is to keep those people in hospital because the local council has to set its balanced budget. It is incentivised by the system to limit demand, and the NHS can run those deficits. So locally, and in every local ICB system, that's the sort of the revenue and capital dynamic. And it's driving, I think, investment in hospitals because they're capital, they're shiny, you can cut a ribbon on them, and it's preventing people from investing in social care and other types of community prevention and care, public health grant, all of those things that you could do to prevent people getting sick in the first place. So I think we just need to have a sort of a spend to save mentality. And one of the things that I hope will come out of the sort of renewed focus on social care is that we'll look at how much it's costing the NHS to not fund social care. Because we understand the cost of social care. We know it's going to cost billions, for example, to provide free social care. And that's a horrifying prospect when you have a tight financial situation. But what we aren't looking at is how much is it going to cost the NHS if we don't provide the social care, because we're probably just storing up a huge amount of money to be funneled into the NHS into the future. And politically, at the moment, that's more palatable. People are more comfortable with spending on the NHS than they are with spending on local government, essentially. So for me, because I'm an accountant and that's how I think, rewiring where the funding flows through is really, really important. And that doesn't necessarily change who's delivering the services. I think local authorities are probably the best place to deliver social care and public health measures. But I think incentivising them constantly to restrict demand with their balanced budget requirement is part of a significant problem that we've seen in the system.
Helen, thank you so much for that. That's absolutely fascinating, particularly about the incentives with regards to the NHS being able to run deficits and local government not. You are, though, suggesting challenging the Treasury way of operating, which has, been entrenched for a long time. And I think, we saw some attempts possibly by Jeremy Hunt when he was Chancellor to challenge that a little bit. It's very hard to, to pit yourself against the might of the Treasury. Or maybe other panellists will have a view and be more upbeat, but you're essentially asking the mindset to shift from the sort of the day-to-day to a long-term picture where you get returns a long way down the road, which the Treasury doesn't like.
I mean, I think that's true, and I think that's the problem with our political system. And also, you have to be economically responsible. You can't, run up huge in-year deficits with promises that it'll all be all right down the road. But I do think we need to have an awareness of the cost of not changing how we operate. And the future cost incurred with that, and an awareness of opportunity cost, which I think most finance people would be comfortable with. There is a cost to not doing something, and I have to try and find the least cost alternative, as well as obviously the wider societal benefit. And when we just think about local authorities, at the moment they are charging ever increasing amounts of council tax, and for the vast majority of people, they're delivering a worse public service. And that's very damaging, and it's very damaging for local economic growth. It's very damaging for people's trust in politics. And so, for me, we just need to detach the way that we channel that funding to social care, so that local authorities can feel a bit freer to operate based on need rather than on what they can afford.
Thank you. And Sally, I talked about the NHS as being a sort of all-tanker and Wes Streeting having an idea of the direction, but a piece of research by the Nuffield Trust, which I quote all the time, shows that actually the resources are still continuing to flow towards acute. And I just wondered if you could explain why that is, why the opposite is happening when, Wes Streeting is not the first person to say I'd like to have more preventative and community medicine. He's not sort of alighted on this unique idea. So why hasn't it happened before? And can you cheer us up at all, or are we all going to be drinking by refreshment break?
I definitely can't cheer you up, I'm afraid. The shift of resources towards acute is forever trundling onwards. I think in
Forever?
Yeah, in 2016, which is as far back as the detailed accounts data go, about 55% of total NHS spend was going on acute care. It's as of the end of as of April this year, last year, April 2024, it was up to 60%.
Right.
That's a new analysis we've just completed, not yet published. I think so. Why? So one of the reasons is obvious. Politicians talk the talk about wanting to shift where care happens and shift resources, but we see that the headlines and the political point scoring is around waiting times for elective, for emergency care, and culturally it's always been at the heart of the public's perception of what the NHS is. I think in terms of what's under, but we have had this sort of long expressed desire to change that. What I think is almost a political consensus that care should, where the location of care and spend should be shifted. What I think is much less clear is what the rationale for that is. Right. So politicians will say they want to shift care. Why? Do they think it will save money? Do they think it will improve the quality of care? Do they think it will improve the quality of life? That is likely to be a much more a really big consideration in terms of adult social care. And I think because we really don't have clarity on that, it's, you know, the debate and the discussion actually can't really be targeted, and you certainly can't make a decent argument to the Treasury. We know what the Treasury, what at the forefront of the Treasury's mind would be saving overall cash. Yeah, so I've talked a little bit about where things are at the moment in terms of where spend is going. Community services, the spend has actually fallen from about 8% in 2016-17 to now nearer 7.5% in the financial years just ended. There's quite a lot of interest at the moment, again, in government, in NHS England, around setting an investment target. You know, that's been sort of one of the tools in the box. We can increase spending in community, maybe primary care as well, by setting a figure or setting an ambition to grow that. That's been done in mental health. To a certain extent, it has happened. So mental health has increased its share of the NHS spend pie in recent years. The problem with investment targets is that, like sarcasm, they are the lowest form of target. We have an investment target when we can't target activity because we're not good at counting activity, or when we can't target an outcome improvement, which is, I think many would agree would be the kind of the preference. The problem with community services is that a lot of what goes on in community services we don't have good granular oversight of. And this is care that's often happening in people's homes. It's really hard to count. It's really hard to measure. The NHS has been around this many times. When the tariff was introduced under the last Labour government, there was a desire to a tariff, by the way, is kind of a pricing mechanism where you're paid for every patient that goes into hospital. It's really easy to count patients that go in and out of hospital. It's easy to see what happens to them. It's much harder to work out what happens to a patient who's receiving mental health care in the community, or indeed, a home visit from community services. So that is going to be a real problem in terms of tracking activity, tracking outcomes. I think there's a risk that we'll end up with just a spend target that won't necessarily lead to greater productivity. And I think that one of the how that that sort of comes back around to my kind of opening comment about there being a lack of clarity about why you want to do this. If we were to have an investment target, for example, I think ideally we'd want to have that alongside some stated ambitions about the sort of activity we want to see increase, even better, the sort of outcomes we want to see increase. But we need politicians to be clear about what they are, and being clear about what outcomes you want. Do you want improved quality of life in certain populations, certain age groups? Do you just want to have more of this type of intervention that we think, for example, might avoid hospital admissions? That requires some bravery and leadership.
So it's quite broad brush at the moment, in the sense that we have the stated aim of moving away from acute, but as you say, there's no, I guess it's January, so everyone's being bombarded by fitness content. There's no why. Like, why are you doing this? And my kind of understanding of where Labour is they say their why is basically because this sounds good and we think it will save money. And will it necessarily save money? Will it actually, possibly mean that people's lives are better? They're not in hospital, which no one, particularly wants to be in a hospital, but it might not be cheaper.
It might not be cheaper. The evidence is not strong. And it will differ between different types of services.
Right.
Do you want to comment there?
I'll pick up on that, yeah. Excuse me. Oh dear. I need some community care. Thanks. Actually, caring for someone at home isn't necessarily cheaper than caring for them in a hospital, because the hospital's costs are effectively sunk. And the Danish example is it becomes cheaper if the counterfactual is not having to build more hospital accommodation or being able to shut a hospital. So Hungary, for example, I think a number of other countries quite successfully redesignated a lot of their hospitals into residential homes or shut them completely, and that liberates money. But you actually have to shut something for the cost of... So the counterfactual is not building or shutting. And that is an issue. I mean, having said that, in December, 14% of hospital beds were occupied by people who could have been cared for at home. Some of them needed social care, of course, but quite a lot of them needed some form of community support. a lot of that community support is also bundled with social care, so the two go together. So that's 40% of the beds is what, 12,000 beds. That's a lot of hospitals. You probably wouldn't shut them, but you can then make them more. You can make them more productive. I think also, I suspect, being interesting to look at the international evidence on this. But the last thing I saw is that we are admitting more people to hospital for conditions that could be managed in an ambulatory setting, at home or in some form of ambulatory care, than quite a lot of our neighbours. It's a bit tricky to disentangle because we've started counting everyone admitted for a 0 day as an admission in quite a lot of hospitals. So it may be distorted by that. But again, so there are opportunities to prevent people coming into hospital and to not be in hospital. And we also, I suspect, have big opportunities to have fewer people dying in hospital and dying at home, which is what people's preference is. So there are some quite good reasons why to do this, but you need to not be naive and suddenly think, oh, we'll make this shift and we'll save a lot of money. You may prevent the need to spend money, but that's not quite the same, and it's not quite as attractive. The bottom line on this for me is that this represents a massive policy failure consistently by different governments and by NHS England and by the Department of Health and Social Care over a long period. I have a fantastic quote from Simon Stevens, which I think is worth sharing with you. It's from 2016, and he says, if anyone 10 years ago had said, here's what the NHS should do now, cut the share of funding for primary care and grow the number of hospital specialists 3 times faster than that of GPs, they'd have been laughed out of court. But looking back over a decade, that's exactly what happened. And it's largely happened since 2016 too, not quite at the same pace in terms. So there is a sort of actually getting a policy grip on this, and the Treasury are certainly somewhat implicated in it. And I think Sally's put her finger on another problem, which is not many people actually understand what community services are. We have difficulty measuring what they do. The providers know what they're doing, but actually we don't have a global view of that. And we've tended to develop community services by initiative rather than by strategy. So you see in the same in mental health, this sort of this stratification of different initiatives, like archaeological layers of different things piled on top of each other, without there being a kind of overall strategic approach to it. Where we've developed new hospitals, unlike the Danish example, people have written in their business plans that they were going to invest lots of money in primary care and community services, and it reduced admission to hospital and it reduced length of stay. None of those plans ever got properly evaluated, but when we did look, if you do look at them a bit, none of them actually delivered any of their promises, and they often didn't even keep the promise to increase the investment. So we've had a sort of lack of strategy at the national level, a lack of policy grip, or even total policy failure, and then I think a sort of relatively weak approach to the planning and management of these community and other out of hospital. And that what a strange phrase that is. It's out of hospital, defining it by what it's not. Very, very NHS that. We haven't had a local strategic approach to it. So I think the lesson that you take from Sarah's analysis is actually long-term consistency of purpose, proper strategy, and a willingness to shut things. Unfortunately, we've shut a lot of our hospitals already, so some of the advantages, some of the opportunities that will be available to other countries, like Germany and Austria, for example, where basically there's a hospital that in Germany, if you throw a brick, it'll probably hit a hospital. We do not have that opportunity to do that. So we've kind of spent the dividend that we could have had already, and it's not clear on what.
To be fair, I think if you threw a brick in this country and it did hit a hospital, it would already have a broken window anyway. So, it wouldn't cause that much more damage. Helen, I know you need to leave now for a meeting, so just to, release you if you need to go and reassure the audience that she's not storming out. She's just actually
Can I just comment on something though, because we have talked a lot about saving money, but at the moment, because the capacity is 96% or whatever in hospitals across the UK, the implication of that is not just that we're spending more money, it's that there are people who aren't able to access care. There are 18 ambulances lined up outside the hospital who can't hand over. There are people on corridors receiving poor levels of care, no dignity whatsoever. And there are people calling ambulances, either lying on the floor for a long time, in the case of some of my constituents, or just being told to make their own way to the hospital. So we can talk about saving money, but we need to not lose sight of the fact that having hospitals at full capacity and having not taken the advantage of investing in care in the community means that some people are just not receiving care. And if we have an aspiration for everybody to receive care, I think we'd all want an ambulance to come if we thought we were having a heart attack or stroke. Then we have to grip this problem, because it's not acceptable when we are asking people to pay more and more tax to say to them that those basic services that they expect aren't available to them.
Thank you. That's really important.
Thank you.
We're going to open up to the audience now for Q&A and further discussion. I've got a note here that I'm looking for Steph Lawrence from the Queen's Nursing Institute. There we go. Yes, you have been selected to make the first response, whether or not you want to.
Good morning. So my name is Steph Lawrence. I'm the Director of Nursing and Deputy Chief Executive at the Queen's Nursing Institute. I think a few comments from me. So we talked a lot there about ED, waiting times, ambulances stacked up outside hospital. I think there's unseen risk in community. So I am an NHS retiree as a chief nurse from a community trust. We had work left undone every single day. So the risk that we're talking about with ambulances piling up outside hospitals, we've got patients in the community not receiving the care that they should need. That can include end-of-life patients. That can include patients with complex wound care. That does mean that patients die and have serious harm as a result of not receiving that care. And I'm saying that knowing that that is absolute fact. So I think there's something about that we need to consider, because I think that is not visible. It's not collected, as people said. That data isn't there, but it is happening up and down this country every single day. I think there's also something about we layer different and new shiny services on top of what we've already got. We've got to stop doing that. We've got a core service that needs building, fundamentally strengthening, and that will do the work that we need it to do. So our district nursing teams, those teams that work in every town, every country, every village in this country, are the people who will help us to do this. But we've got to reinvest in them. We've got to make them feel valued, because right now they don't feel valued. They don't feel that there's anything there for them, and they feel that all the pressure is on them to continually absorb work from the hospital, work from the local authority, because we also talked there about local authorities leaving people in hospital because that was cheaper for them. They also leave them under the care of NHS community services because that is cheaper for them. That's not a dig at our local authority colleagues. We need to work closely with them. They haven't got the resource either and the infrastructure. But every time somebody gets left in a district nursing team, it means that there's no capacity to take that next patient, and actually they need to move on to social care care delivery rather than it being delivered by the NHS.
Thank you so much for that. Would anyone on the panel like to respond to Steph's points? Nigel, you look like you're champing at the bit.
I should stay in interest as being a trustee of the Q&A. So if I agree with what's just been said, that would be unsurprising. I guess. I just wondered. It has, as I was listening to, of course, a lot of that work is also supporting carers. We haven't mentioned carers, the support to carers in part of this. I mean, I think one of the interesting things about if we compare our systems to, say, Southern Europe, although they are having difficulties with this, there is much more expectation that carers take a strong role. That's being disrupted by the fact that populations are now more mobile. So you may not, your family may not be so proximate to you. But I think there's still we have had a carer strategy. I fear it's gone the way of quite a lot of our other strategies in this direction. But and those community staff, of course, are very important about also providing confidence and support to carers too. So that would be that's my other missing bit of the equation here, I think.
It's a really interesting point about Southern Europe, and I think something that some Conservatives have viewed from probably the opposite angle to you, which is, why don't we be more like that? Why don't people take more responsibility for their parents, which is an interesting case for a politician who wants to be liked to make to a working population of women, for instance, who probably also have childcare responsibilities and are hundreds of miles away from said parents, but and also whose parents probably don't want them to be doing their intimate care, for instance, which I think is another issue that's often overlooked.
We're not Spain and we're not Italy and we're not Greece, so it's not going to happen, right? And there are economic costs to relying a lot on the informal care. But given the fact that there is a very big informal care sector, then we should be doing more to support it. But I don't. It's not the answer. But but supporting carers certainly in the long, will help keep people out of hospital, help meet their wishes for end of life care more effectively than not. So I think it's just it's an added sort of tool in the box that we should be paying more attention to.
Sarah, your international tourism was mostly colder countries. I think Alan Milburn seemed to spend a lot of time in Spain, which was smart of him.
man.
Yeah. But presumably those countries are more comparable because they have, you talk about stronger community models in terms of local government, but they probably have similar societal, working women, for instance, in fact, much better in some of the cases.
Yeah, I think there are some parallels there. And also a lot of these systems are also tax-based in the same way as the NHS is. They have, but I think even though they're very tax-based, one thing that is also different about them is that those Scandinavian countries I described are quite decentralized at the same time, which might seem a bit strange, but actually the local authorities I described who oversee community services have a lot more control to really design and set incentives and really own and have the accountability for making this shift happen, which is also why some of those hard baked-in incentives might make a lot more sense in a system where you're giving a lot more responsibility, but you're also giving a lot of accountability in terms of those financial incentives. So there are some interesting differences there as well.
Sally, do you want to chip in? Or?
I'm just slightly distracted by the sort of the gender dynamic, partly because I was looking at the community services data set, such as it is yesterday, and the skew on who's actually receiving community services is quite significant. It is older women,
right?
That makes and obviously women do live slightly longer, but I think it's also telling you who's looking after older men, and then there's nobody left to look after the older women. So it feels like in terms of resourcing, it's actually it's a societal equity issue as well as anything else. So.
Absolutely.
Okay, time for a question. Yep, hand up there. There's a microphone heading your way. Thank you.
I'm going to struggle to stand. I've got a bad back at the moment. Sorry, I have to remain sitting. I'm Richard Lewis. I'm a distancing here in Nuffield, but also I'm speaking as trustee of Helpforce, the national charity that supports volunteering in healthcare. And that's just picking up on Nigel's point, because I think when we talk about primary community services, the big advantage of them, of course, is they're embedded in communities. And I think the point you make about carers is a very important one, and it also applies to volunteering. And we've seen since COVID that the pressure on volunteering has been immense, and that people are finding it harder and harder to volunteer for reasons of cost, for reasons of the amount of discretionary time that they have. And it feels to me that actually some part of our strategy in terms of increasing the sort of social infrastructure that supports care services in the community is about a carer strategy. It is about enabling people to volunteer and to be part of that solution that's embedded in those communities. And that is the strength of community and primary care services. And it's not a quick fix, and it's not a free money. So, well, in some ways it is free money actually for the NHS and care services, because the evidence base is really very strong about the impact, obviously, of carers on health and care support services, but also on volunteering. So it feels like it's a missed trick here, and I'm hoping that in terms of Darcy's long-term plan that comes out, that there really is a focus on the sort of informal but very important elements of care services.
Thank you for that question. Sally, I know there have been some pilots in this country looking at getting the community more involved in social care and supporting people with long-term care needs. Nigel looks like he's excited by this as well. So
I'm quite excited
either
by
of
this,
you can fight each other to ask the
Nigel's very welcome. No, Nigel's very welcome.
So I was involved in a piece of work with local trust and NHS Confederation looking at there's a lot of really interesting asset-based community development type activities going on under the radar in a lot of places. In fact, we should get Thea to come and talk about some of the work that's been done in Leeds, because it's really stunning. It's quite small. It's a bit chaotic and it looks from a policy point of view, it looks a bit sort of hard to regulate and categorise. But I think a lot of it, however, is probably more supporting working age adults and families with children. But the examples in that research that the Confed have published really, I think, speaks to the reach and power of these things to help improve people's lives. I think once you're sort of starting to be in the care requiring lots of actually hands-on care, they're probably less effective, but they do provide you with a sort of range of sort of other options, social prescribing, support on how to access various other services like housing and for example, and creating a sort of neighbourhood feel where people can help you with tasks, but it probably it's a really sort of good substrate to build on, but it probably isn't going to help you with personal care. But it does mean that there are other resources that the staff working on the community can call on and can mobilise. One of the problems is that the areas with the least social capital are often the areas that are also the most deprived and most in need. So there is a sort of there is some need for investment. You probably can't do this entirely on the cheap, but as you say, Richard, it can generate huge amounts of social value, but without you having to spend vast amounts of money. The risk is if you ask statutory services to run it, particularly in NHS, they may spoil it. So it does have to, to some extent, be grown bottom up. But,
so keep the NHS well away from it, and it will be okay.
No, it can help, but it needs to not take over.
Right, I see.
Which it
Well,
tends
that's
to want
quite
to do.
difficult with a control freak administration, Sally. What do you think?
Well, also Richard said, there could be some free money in here for the NHS. Obviously, as Nigel's alluding to, that it will need to be supported, for example, by the DWP if it's really going to go places. So it's kind of, it'd have to be part of that sort of cross-government thinking.
Yeah, the DWP has often not proved itself to be really very interested in those sorts of things, unfortunately.
I feel like our school report card for government departments is sort of expanding, but every page is very disappointed and must
could
try
do
harder.
better.
Could do better. Sarah?
Yeah, I think I've looked less, to be honest, at kind of the informal care structure in some of these systems, but one thing that does interest me about the Danish experience is that they kind of have the opposite problem as we have in this country, in that they actually have a hard time getting nurses and other healthcare assistant roles to work in hospitals. The community jobs are much more attractive because, like I said, there's a lot more local control over kind of the terms and conditions of those roles. They're a lot more flexible. They are closer to people's homes. They have that embedded community aspect to them. So when I talk to experts in Denmark, they're actually like, it's our hospitals are now, we've almost overcorrected the problem, and now we're having to kind of rethink our strategy. And I think that gets me to another point, is that this work, we talk about policy failure, and that is all absolutely true, but part of me feels like this conversation, we may never stop having this conversation, that even in Denmark, they're having to do more incremental reforms because they're seeing, again, more pressures rise up in hospitals. They're seeing that the gravitational pull of hospitals giving an aging population, people living with more complexity, they're now having to introduce even harder incentives to, again, kind of balance the playing field. So a part of me feels like we've never really gotten this right, but even if we got it right, we might be having this conversation for a long time, just because the work on making this shift happen isn't easy and is kind of baked into this kind of the way our health systems and societies are at the moment. So that, Gloria. Yeah.
Right, another question. Somebody here at the front, just to give the mic a workout.
My name's Liz Jones. I'm the Policy Director at the National Care Forum. We're a membership organisation for not-for-profit providers of care and support. And I was interested in our colleague from the Q&I and thinking if we could perhaps explore a bit more how we resolve that tension in the commissioning and funding arrangements around helping people to get out of hospital and stay out of hospital, and ideally not go into hospital. Because certainly our members report a lot of challenges in the process, even more challenges in payment and the kind of value placed on the expertise that helps you either do that preventative work or have an ambition that when somebody out of hospital, the ambition isn't just to free up the space. The ambition is to do it once and do it well. And none of those things seem to get measured, and none of the kind of commensurate partnership approach to helping that happen seems to be embedded. There was reference to the Better Care Fund and a new policy document, and we said, oh, great, have you written it? Can we put some wider input into it? Oh, it's already done, thank you. So it's that kind of, how do we bring the expertise and that shared endeavour where everybody knows what they want to do well, but the money and the culture really seems to be a barrier.
Thank you for that question. Sally, are we measuring outcomes? Are we measuring progress? Do we know what we're doing? in life, but particularly in this policy area?
I was going to answer this question by saying I've got some optimistic thoughts about this actually, but a bit of a downer. So as I said before, we don't have a great oversight about what's happening in community services at the moment. We roughly know aware about half of the money that's spent on community services. There's about 10 billion spent on NHS delivered, ran community services. We have oversight of about half of that. Right. For acute care, it's more like 90%. We know how 90% of that money is spent, i.e. what sort of treatments are received for that. But there's so many. It's been done so. I don't want to say badly because it is, as we said, it's really difficult stuff. Yeah, but it feels like there are a lot of potential opportunities to improve things. So one opportunity is, as I said earlier, to be really clear on what the purpose and the intention actually is. So that would help. The other reason I'm relatively optimistic is, although in the past we have had various attempts to sort of incentivise getting patients out of hospital, is something called fining councils for when there was a so-called delayed transfer of care, used to be called bed blocking, as we discussed, that often that they actually weren't imposed because they were just going to actually make the problem even worse. We've actually in the recent past we've had the bizarre situation where if hospital if too many patients are perceived to be going into hospital, there's actually a financial benefit to the commissioner for that. So hospitals have very little, or feel they have very little ability to shut their doors. That's what they talk about. That's their response to when councils say, well, you're not allowed to overspend. They say, well, we're not allowed to shut A&E. It happens very, very rarely. So the incentive mechanism perhaps hasn't actually been designed very well. There's so as I said, commissioners in the past have ended up paying a lower rate when a hospital goes over the planned level of hospital admissions or planned lengths of stay. The other reason to be relatively optimistic is about half of NHS-run community services are actually run by organisations who majority deliver acute care. So if we're having this sort of relatively lowly ambition, which is let's just get patients that don't need to be in hospital out of hospital, a lot of those the people who are running those services who can do that are actually they should be super incentivised. Yeah, and they have control over the levers. They are employing the staff who are running the community organisations. It should be possible. But I guess we could flip that and say, well, even though that happens, they so far haven't done it. But around the country, we have got multiple initiatives. In Oxfordshire, the University Hospital Trust there is running a community end-of-life care programme. And what the evidence will show on those is this isn't saving huge chunks of money, but it's improving people's quality of life, and it is liberating hospital capacity, because we know there are literally millions of people waiting to receive hospital care at the moment.
I think the slight worry about that is that the community services are kind of not really just about keeping people out of hospital.
Yeah.
They do a whole bunch of other stuff which is really important about people's quality of life, and eventually it might prevent them from, but that isn't the focus. And the kind of operating model that you need for running a quickly responsive, keep people out of hospital, get them discharged quickly, is a different operating model from the routine care for people over a long sort of career of care. So I think it's quite challenging for hospitals to try and balance these different business models within them. And I think those that have done it well have done it well, but it's taken a lot of work and thought. And I think there was a sort of idea that, if we'll just integrate it into the acute hospitals, then that will make everything fine. And I think the evidence is lacking on that. I think that a number of them have not really managed to do that well, and in their worst, there's been a bit of asset stripping sometimes as well. So because one of the problems has been we've had these cost improvement savings which have been imposed on providers for God knows how 30 years. Yeah. The problem if you're a community trust, if you're a community provider, most of your staff, most of your cost is payroll. So your ability to become efficient basically means you have to cut service. You probably cut services or don't invest. Whereas if you're in a hospital, the opportunity to become more efficient by improving your processes, your facilities management, a whole bunch of non-pay things. Mm-hmm. So the whole structure of the way that's worked, I think, has mitigated against whoever is running these services getting a better integration between them, or indeed a proper investment focus. I like a bit of optimism. I'll keep with the optimism, but I'm not yet convinced. Yeah.
Sarah.
Yeah, I think your experience speaks so much to the complexity that's baked into our system because of who's accountable for what. And I think, and again, this is just a contextual difference in a lot of the systems I described, but this divide between what's social care and what's the NHS in these other countries doesn't really exist. It's local authorities who are overseeing all community health and long-term care services. And I am not proposing that we do a huge structural reform to change that in our system. I think we have the system we have to some degree. We probably could cause a lot more harm than good if we made that change. But I think it's just a lot of these, there's less of a need for something like the Better Care Fund and some of these systems we described, because that complexity doesn't exist because it's one group of people making joint decisions on all these services together. And I just think that's another reality, contextual factor we need to be aware of as well.
We have time for one more question. Chap in the front row there in the green jumper.
Thanks, lucky last. My name is Chris. I work in acute care, so I work in the NHS Trust as a subspecialty clinician. But I'm actually from Australia, so it's a very different system to me. But there are lots of similar problems. And I guess I just wanted to ask, Australia has a big move as well moving towards home care, sort of community care. But talking to local clinicians, there's a lot of pessimism about trying to get over that bump of the problem with acute care eating up so much of your resources. Yeah. So, like the return on investment for community care or GP care, as you mentioned, is 10 years, 20 years. Yeah. In the long term, it probably is, if not a cost saving, at least more humane. But how do you incentivize that? And I guess if you're doing that in the short term, particularly in those Scandinavian countries, was there a short-term pain when they closed half their hospitals? Because I would imagine that that sort of acute need is not going to go away soon. Maybe 10, 20 years you can reduce it, but how do you do that there and then for that change?
Yeah, thank you. Sarah.
Yeah, it's such an important reflection, and a question I have is, how have health systems got the politics of this? How have they endured that short-term pain that seems like an inherent fact of this? And we are doing more work to really understand some of that in depth. But I think what I can say now is that, when I've spoken, for example, to Danish experts, I've asked this question and they say, well, there's an acceptance that if hospitals are going to do less, that everyone else has to do more. They've kind of accepted that our lives the pressures that are mounting in hospitals will only get better if this happens. And I think they've been able to kind of make that case quite strongly, but I'll be the first to say that Denmark doesn't have the waitlist crisis that we have in the UK right now. Their waitlists are growing, and there is growing public dissatisfaction with it, but like we're not starting in the same place, and that's why we're doing more work with the Irish experience is so interesting to us, because they are kind of starting from a much more challenging situation in their acute sector where wait lists are growing and uncontrolled. They've had a really difficult time with coming out of austerity, where they've really limited funding for a decade now. So I think some of their context is more relevant, which is why we want to kind of ask this question: is like, how are you getting there? How are you navigating this? Because I think, yeah, to have the long-term gain, there's going to be short-term pain, and I think that's a fact, and how we sell that politically, to me, is the big question. So sorry, just to reinforce your question rather than answer it, but I think it's a really good one.
Thank you, Sally.
Yeah, I'm not sure we know what the return on investment in acute care is. Certainly the marginal benefits of ever increasing levels of specialisation probably don't have a fantastic return on investment. I think it's probably not really a cash or a cost measuring exercise. I think it's much more about our kind of political culture and the way we value shiny new things that happen in hospitals. So I think it's probably a cultural change that we need, as well as sort of good, robust economic arguments. I was really taken by the book. I'm going to mispronounce the author's name, but Being Mortal. Thank you very much. About kind of a similar problem in America, and we share many of the sort of the cultural issues that America has. We want to endlessly pursue the new advances in medicine without possibly paying attention to kind of the stats, people's general quality of life. And I think that's probably the cultural hump we have to get over in the next discussion.
Nigel.
Well, yeah. I don't think there is any evidence that the extraordinary multiplication of specialists and subspecialists has produced the level of sort of quality improvement. And the problem is, as medicine is becoming more specialist, the patients are becoming more comorbid. So we've kind of gone in the wrong direction, and it's driven by professional aspirations, not by patient need, I think, quite a lot of the time. And it's going to be quite hard to turn it back. But that's one of the reasons why the money has got sucked in, because when I first started working at a hospital, I think there was 4 general surgeons and a couple of urologists, and now there's a surgeon for everything, and thousands of anaesthetists and lots of subspecialists. There are 9 subspecialties in orthopaedics. I mean, a lot of this is good, but some of it is unaffordable, and it's also, of course, that these people represent a very substantial political power, which, with great respect to the QNI and the advocates for community services, are going to find it very hard to win against people advocating for not just bright and shiny, but really quite impressive bits of specialist hospital medicine.
Yeah, big kit is always something that attracts politicians to point at as well, which I think is another thing. I'm afraid we have run out of time for this discussion, but thank you so much to our panel, and thank you to those who've asked questions. I think one of the falsehoods or the false beliefs in politics is that this shift from hospital to home is a no-brainer because everyone's going to be happier, healthier, and it's going to save lots of money. And we really have dissected that during this discussion. I think we've really clarified what needs to be discussed within government over the next couple of months as they develop their plan, which is what do they want to do, what do they want to get out of it. And we've also, thank you, Sarah, for taking us around some of the other countries that in many cases Britain should be aspiring to mimic, rather than, as I said at the start of this discussion, feel as though everyone else in the world could be learning from our way of setting things up. I don't think that discussion has suggested that we are necessarily the textbook at the moment. But I would just end, this has not been the most uplifting discussion in some senses, but as a committed pessimist, I would like to say that we are always the happiest people because our low expectations are always exceeded. So hopefully that will be the case in this. But thank you to our panel.
Thank you.